So I'm going to ask you to hold some of those thoughts and some of that ambition, and hopefully that will be useful partly for kind of putting some of this in context, and it may be useful for some of the challenging questions we want to ask about some of the yes but how of all of that. I spend a lot of my time helping people with the yes but how, and that really interests me. It's not often people say this in a talk, but do feel free to take photographs, particularly if you're interested in the slides or anything that comes up, do feel free to photograph that. And all of the slides are available there online as well. If you're a member of the Twitterati, my username is Robert Varnam. What I'd like us to do is do a bit of a stock take, a view about what people are doing around the country in things like the Prime Minister's Challenge Fund and others, but then also for me to share some thoughts about some of the yes but how that I think might be helpful for what you're doing in South Worcestershire. So if we start just very quickly by doing that little stock take, hands up if so far you're getting a sense that things in general practice in the last 6 months have been more challenging than 5 years ago. Quite a few of us. Okay. It may reassure you to know that you're not alone. I'm really pleased, though, that you've been looking for a long time to the future, because actually there is a temptation, and it's an understandable one, for pressure to cause us to look inwards, to look just down at ourselves, to miss some opportunities, and particularly to take our eye off the ball, an eye off the purpose, which is doing well for the people we serve. And so the fact that you, even last year, were looking at doing Prime Minister's Challenge Fund stuff because you've got that passion, you've got that vision already, I think it puts you in a great position already. And I'm really glad that we've got a focus in the NHS at the moment on access in general practice, partly because I have some strong personal experience of it, but partly because I think it unlocks a lot of things. And I'd like to tell you a story of a seminal moment for me in access. I'm a GP in Moss Side in Manchester, and done a variety of other things in my career. I've worked in primary care trusts, I've worked in the University of Manchester, done a lot of training, a lot of research into quality, patient safety in general practice, and I've spent a lot of the last 10 years helping other people to improve their work and their performance, and helping health systems and governments to improve big systems. And it's really interesting how often access to services is a sticking point, and if you can improve access, all sorts of other things improve as well. And that's not just from the perspective of patients and carers and families, that's from the perspective of staff as well. And for myself, an incident that I never ever will forget was the first Thursday that we as a practice moved to working on the phone. We'd been talking about it for a while. We ended up in the end planning it very badly and implementing it in a real rush. And I remember this Thursday morning, I was halfway through the morning and I had a call with an elderly lady who I didn't know very well. And she was really apologetic, and she said, "Oh, I'm really sorry, I didn't mean to mind you, doctor. I didn't want to trouble anyone. I just wanted to make an appointment." So I said, "No, it's okay. I'll tell me what's going on, and I'll help you to get what you need." And she said, "Well, all I wanted was just make an appointment. After the weekend, 2 or 3, 4 days. It's fine. It's not. I don't want to trouble you." I was going, "No, it's all right. Really. Tell me, how can I help you? Don't have to apologise." Well, within about 20 seconds of her starting to tell me what the problem was, I was thinking, I think you're having a really big heart attack right now. And so I talked her through. I said, "Okay, I'm going to call an ambulance. I want you to put the phone down. If you've got any aspirin nearby, don't worry, just wait by the phone." Talked her through all of that. and got the letter back from coronary care as she was discharged, and for the medics in the room, she'd ruptured virtually all of her papillary muscles, and the idea of this woman waiting to see the GP for 2 or 3 or 4, don't worry, it's not a bother, I'll see you after the weekend. Well, she would have died alone in her rather grotty flat round the corner in Moss Side long before she got to see us after the weekend. She's still alive, and this was about 10 years ago. And she's alive because we just changed the way we did the appointment system. And what's really interesting is, at the end of that first day, even though we did it really badly and it was really chaotic, at the end of that first day, we felt better. And the first thing everyone was saying was, hey, this is much better. I'm not having arguments at the reception desk with patients. And we're not starting every consultation with the patient complaining about how hard it is to get to see us. And I said, and you know what? That phone thing has saved someone's life today, I reckon, if she makes it through whatever they're doing to her in the hospital at the moment. And I think access is something that's very easy to see as a one-dimensional issue. But actually it can be a key to all sorts of things that matter to all of us, whatever your role is. And so for me, access has always been something I've been very interested in. So it's kind of a bit bizarre for me that I find myself working at NHS England part of the week, and helping to support the network of groups who are doing stuff in the Challenge Fund. So I thought I'd tell you a bit about what people are doing and share some of what we're learning from it. The Challenge Fund is, as far as we can tell, the largest single-funded primary care innovation programme that the world's ever seen. It's a really big deal. So we've had 2 years of it now, we're in wave 2, and it's covering 57 groups of practices, over 2,500 of them, 18 million patients. So it's a large bit of the country who are involved in this already. I think even more telling statistic for me is the fact that when that first announcement went out from the Prime Minister, and it was a very political agenda behind it, applications came in from over 250 groups of GP practices that covered nearly 2/3 of the population of the country. I think that's telling because in recent years I've heard a lot of people talk as though general practice was finished. As though all of the spark had gone out of it, it was heading into inexorable decline, that governments were trying to finish it off so they could sell it to Tesco, and that a lot of people say, and this is particularly in higher management levels in the NHS and in government and most politicians, the fear was even if you gave money to general practice, they'd waste it or they'd just buy themselves nicer cars, and nothing much would happen because the spark's gone, they're just serving themselves. And I think this has finally put that to rest. It has shown that general practice is alive and well. It is full of committed and creative people who, even though they are working far too hard, and it's getting harder, they're actually up for more of a challenge because they can see that they could do things better for their patients and their communities. And I just think that's been an amazing thing, just the signal that has sent to government, to politics generally, to the NHS senior echelons, that actually this is a part of the NHS that is not dead, it's alive and well. And if you give it some space and if you give some money and say, what do you think people round your way would like and would benefit from, you get some amazing things happening. The next thing that I think's been really exciting for me personally is that what people have been trying to achieve has been so much more holistic and comprehensive than what mostly we've done in the NHS when we've tried to improve access in general practice. Most of the things that have come in the past about general practice access have been about speed. They've been about making it easier for people to get quickly through to someone to see them. And that's obviously really important, and there are some people who get more ill because they can't get speedy access. But actually what's really exciting for me is, faced with this political ask to open for longer hours, the people in the Challenge Fund, you included, have said, okay, we'll do that, we'll open for longer because some people can't get to see us during the day very easily, but we will also do stuff about the right place. Some people, it's better to do it online or on the phone, and that serves us all better. Actually, right time is important, but for some people that doesn't mean quick. It means next Thursday, because that's when I don't have caring responsibilities. And it's cruel to say to that person, you can't book ahead. So we're going to do both quick and scheduled. That's what right time means. And they've been saying, right person. Actually, sometimes I'm not the right person. I'm lovely, obviously. GPs are geniuses, obviously. But sometimes it would be better to see a nurse or a pharmacist, because actually, sometimes pharmacists know more than I do about drugs. Sometimes it'd be better to go straight to a physio, rather than me say, yeah, you've injured your shoulder, I think you need to see a physio. They'll phone you or write to you in a while. Actually, also asking, we need to get people through to the right kind of care as well. It's not just enough to get in through the door to see the right person. That person needs to be providing the right kind of care. It needs to be, for many people, far more proactive, far more joined up, less medical, and that's what good access looks like. I think it's an astonishing measure, astonishing message that primary care teams around the country are sending, that we need to do this, but it needs to look like this. It's fantastic, and it's making the job of me trying to influence other agendas an awful lot easier, to point to it and say, look, it's real and you can do it. But it's not just about a one-dimensional understanding of what good looks like. Good looks like something far more complex, and don't go assuming that every person has the same needs. One size doesn't fit all. And what's great is we're kind of getting that message through. What's challenging, of course, about it is it's happening in very, very difficult times. And it would be foolish for anyone to try and pretend that these aren't very, very difficult times for our GP practices in this country. I recently came across this old photo that my wife took of me when it was the first time I was doing something in commissioning, and we were setting up this practice-based commissioning group, and I was going to join the team, and we were doing some work, and I needed a photo of myself for the newsletter. And I didn't have any of me looking like a doctor, so hence this photograph. And digging this out in the study the other day, a few months ago, I remembered two things that were in my mind. The first was I was doing this because I really wanted to improve care for diabetes people in our patch. It was pretty poor and lots of room for improvement, so I wanted to improve diabetes. But the other thing was I wanted to protect general practice, because I had this fear, and this was a while ago now, that everything that was being done in the NHS at a national level seemed to be focused on giving more money, time, power, space and permission to hospitals. And I felt that the best bit about the NHS, the bit that's most unique internationally, was general practice. And general practice was being constrained more and more and more, and we were finding it harder and harder to deliver our potential or even survive. And I had a concern in my mind 10, 12-ish years ago, whenever it was we were first doing practice-based commissioning, that general practice might be in a terminal decline. And I was motivated to do this commissioning stuff partly because I thought, well, I ought to try and do something to help. Somebody needs to hear this. No one's taking any notice of us, and no one's taking any notice of what's happening. And I think that concern is one that's pretty universal now, actually. This concern that firstly, general practice is really hemmed in and really constrained. That we've got this model of care which is brilliant. We already provide great quality care that's really safe, is a pretty good experience, and it's the best value in the world. So we're already doing really well, but it's got really hard in the last few years. As the volume of work has gone up, the complexity has gone up, funding stayed static and then started falling, and I personally think we've been sleepwalking into a workforce crisis for about 15 years, maybe a little longer. But the second thing is, it feels like general practice has been off in the corner somewhere. It feels like politicians talk about hospitals and schools instead of health and education. It feels like the NHS will, at the drop of a hat, spend £400 million extra on A&E to keep it going for another few weeks, but not a penny on general practice. And it feels really, really tough, and as though no one's listening. And so one of the things that's really exciting for me at the moment is that I started kind of touching the national world in the NHS about 4 years ago, 5 years ago. And in the space of that time, we've moved to a situation where instead of every conversation beginning almost assuming general practice isn't up for it, ... what should we do? Actually now there's this real strong focus on how the system could help general practice deliver more of its potential, and more conversations are beginning with questions like, do you think general practice could be interested in this? Or how would it be possible for general practice to do this? What's the IT like? What would the workforce implications be if we asked primary care to be involved in this? And you see some stuff that's been published really reflecting that. So a couple of publications. One of them was year and a half ago now, the call to action on general practice, which heard from people around the country about what it's like, where they're heading, and what the barriers are, they think, to getting to a better future. And then the NHS 5-year forward view published earlier this year, describing where a group of organisations at a national level think we ought to be heading in 5 years' time, and making the case for more money, that the government needs to invest more money to make it possible, but making some commitments as well that will help transform things a bit to make them possible. And I think that's really unusual, to have two massive policy statements from this NHS that's been ignoring general practice too much for too long, actually saying primary care is one of the best bits of our welfare state, and it's a bit that needs more help and it needs more focus on it. And even committing, so even in the 5-year forward view, it was the first time the phrase New Deal was used, long before politicians got hold of it, saying that actually general practice needs more money, it needs more people, it needs a broader workforce, it needs better IT, it needs better premises. And you know, the week it was published, work started putting some of that into place. So we're in a position of things are tipping, I think, which I think is really exciting. And everyone's talking about change. And here's what's really interesting. It's not just things are tipping because we're going, oh, thank goodness we can rest now. Things are tipping and everyone's talking about change. And I think that every one of us, so whether you are working in general practice or not, whether you are commissioning it or providing it, whatever your role is, I think every one of us should be really good and confident about explaining to people why it is that everyone's talking about change. And I think it's two reasons that are really helpfully combined, because it adds weight to the momentum that we've got. One is the pressure and one is the opportunity. So I've already talked a bit about the pressure and I've already alluded a little bit to the opportunity. And it's sometimes possible to blame other people for this kind of stuff. And I've done some of that already. But actually, the fundamental issue, I think, as Carl was saying, is to do with the work that we're doing and the people that we're serving in primary care. I don't know if you've seen this graph. This came out about 5 years ago. It's a really seminal piece of work by the Scottish School of Primary Care. It's been reproduced hugely all over the world. I've been at international conferences where people have kind of done their own version of this. Here's what it shows. It shows the number of long-term conditions, long-term medical issues that somebody has. And it shows that as you get older, more and more people have 1, 2, 3, 4, 5, 6, 7, 8, 9 more of these long-term conditions. Such that at the age of 75, nearly a third of people have 4 or more long-term conditions. We're living longer, we've got more illnesses to do with growing older because we're not dying of other stuff earlier. Why is that significant? Well, I think it points to the fact that what we're doing now, and this kind of work, seeing people who've got multiple long-term conditions, accounts for between 1/3 and 1/2 of most GPs' working day. These are people for whom the NHS was not designed. Because when the NHS was designed, here was the idea. You get ill once in a blue moon, You go to the doctor's surgery, and the receptionist books you in to see the doctor, who cures you with a prescription. And you have a couple of weeks of taking a prescription, and you're cured, and you go back to work and normal life, and then maybe at some future time your doctor will need to respond again to make you better. And sometimes you go and see your doctor who scratched their head and didn't know enough what to do, so they'd send you to a clever doctor in a hospital, and they would write you a different prescription, or cut off the offending bit, and you'd recuperate for a bit, and then you'd be back to normal life. And then at some future point, the NHS would need to react when you were ill. These people, who are a growing proportion of all of our communities, it goes up year after year after year, cannot be cured. They don't have an illness which is going to be cured. They have not just one, they have several of them. They don't need a specialist, most of them. They need someone who's going to do all of it. But instead of it being an all of it once in a blue moon, it's going to have to be much more frequent. These are people who come to see the practice several times a year, several times a month, some of them several times a week. And we can't cure them. It's not about a cure, it's about living with. And the best way of helping them live with is not waiting for things to reach a crisis and then we respond. It's about being proactive. And the stuff they need is not just more prescriptions from me, it's actually a much broader team. It's a very different kind of thing that's going to help these people live a good life. And that's not only the reason why life is feeling so busy in general practice. It's not just that things are busy and the population's growing little by little. It's that qualitatively we're doing stuff that's way more complex. And actually that speaks to an opportunity that we need to grasp with both hands, which is that our traditional NHS solution